good morning to all of you. So we are warmly welcoming you once again from our homes to join in today's webinar series. I would like to highlight that today we are marking almost surpassing 70 webinar lectures that we have been handling through GMOA Shri. And we invite you to please log into our official GMOA Shri YouTube channel to view all our past lectures and to get educated on all our current topics. So without further ado, I would like to go into some housekeeping rules. As usual, this webinar link will be available from 9 to 9:50 a.m. for all of you to join in. And no late attendees will be entertained thereafter. Each attendee should have attended till the end of the webinar to obtain the certificate for CPD points. And these CPD points have strictly adhered to the NCCPD guidelines. This is also to improve and maintain the standards of our Shri webinar series. We thank you once again for the strict adherence of these regulations to maintain our standards. And we are also currently working on getting accreditation for our CPD webinar series so that you all can have this digital certificate to submit in your postgraduate and any other examinations or any other countries you are trying to apply into. Without further ado, I would also like to tell you that at the end of this series, we will be conducting the usual Q&A session. So please feel free to fill in any queries you have during the webinar into the chat box for us to discuss at the end of the webinar. Also, please mute your microphones and switch off your videos so that there will be no interruptions during the webinar. I would like to focus your attention to today's webinar, which is something very timely and important in our day-to-day clinical practice. So today's topic is hyponatremia, when the body loses its savor. I'm sure all of you are very interested to know who our distinguished speaker is today. I would like to welcome Dr. Himal once again to give an introduction and initiate this webinar for the day.
Good morning, everyone. I hope you can hear me nicely. You can see we are connecting with our individual places due to travel restriction by fuel prices in this country. But we hope we can do it even in this setting. Today's webinar actually a collaboration effects of Sri Lankan College of Internal Medicine and Shri. Let me introduce today's speaker, Dr. Shehan Silva, MBBS, MD, MRCP. Dr. Shehan Silva had his undergraduate education at the Faculty of Medical Sciences, University of Sri Jayawardenepura. After completing his MD degree, he was trained geriatrics, acute medicine, and endocrinology at Edinburgh Hospital of Cambridge University of Hospital in UK. Upon return to Sri Lanka, he worked in periphery as well as central centers, including NIMH. He is currently senior lecturer in medicine at Faculty of Medical Sciences, University of Sri Jayawardenepura. He also honorary consultant physician at Colombo South Teaching Hospital. And Dr. Silva holds the position of secretary at Sri Lankan Association of Geriatric Medicine, and he was an assistant secretary of Sri Lankan Medical Association. His interests include geriatrics, internal medicine, medical ethics, professionalism, and medical education. Dr. Silva, without further ado, I would like to invite you to start your lecture. Thank you, everyone.
Himal, let me get the presentation on. Okay, good morning, everybody. I hope you can see my screen. Yeah. Himal, can you see my screen?
Yes,
we
sir,
can see. We can see your screen.
Okay. So it's a privilege to be invited to do this talk on hyponatremia, which is when the body loses its savor. So I'm thankful for the Society for Health Research and Innovation, along the Sri Lanka College of Internal Medicine, for giving me this opportunity to brief through some pearls in clinical practice. So before we delve into our main topic, I would like to take your attention to something from medical professionalism, so about caring. So let us ponder about this. Is one of the essential qualities of a clinician to have an interest in humanity. Why is it so? Because the care of the patient is, the secret in the care of the patient is caring for the patient. Secret in the care of the patient is caring for the patient. In all what we do, even in this topic or whatever that we go across in our life, let this be something that echoes within our minds. So I would like to go through these areas today. I would like to briefly remind ourselves about the physiology of water and sodium homeostasis. Then I would like to speak about hyponatremia, about etiology and symptomatology, and the clinical workup of hyponatremia and its management. So if you can remember your Gannon or whatever physiology book that you would have read for the second MBBS or in the first year of your medical career, if you can remember all these hormones that come into play, right? So the important aspects of the renin-angiotensin aldosterone axis. Then we had the anti-diuretic hormone ADH system coming in, and the natriuretic peptides, the atrial and the brain natriuretic peptides. If you look into this, if you look into this picture, you see that the concentration of salt as well as the electrolytes and water is delicately balanced by these hormones. Mind you, the arrows in blue are denoting positive directions, whereas red, it's in negative direction. And you see that aldosterone promotes sodium reabsorption into blood while inhibiting potassium reabsorption in the kidneys. Aldosterone promotes the sodium reabsorption into blood, but while inhibiting potassium reabsorption in the urological system. And you see that angiotensin 2 and aldosterone also acts in the same direction. So angiotensin 2, aldosterone, cortisol included, along with angiotensin, angiotensin 2, all act in the same direction. Therefore, it's essential that we know that this system goes in one direction. Whereas you get another system where it's the atrial and brain natriuretic peptide, the ANP, BNP, they also go in the direction, but that is produced by a different hormonal system. Therefore, derangement of these hormones do not affect so greatly upon the sodium connection. But you see that ADH, antidiuretic hormone, acts far downwards. It actually acts on the collecting duct and the distal tubules, and it impacts more on the water reabsorption with minimal effect on sodium. But what does this do? It causes hyponatremia when there is excess of ADH occurring. So ADH secretion is made from the posterior pituitary. It is made in the hypothalamus, and it is secreted into blood when there is increased osmolarity or when there's reduced blood pressure, or again, indirectly when there's angiotensin 2, which stimulates. And you see that ADH causes reabsorption in the distal tubules and the collecting ducts mainly. So we come into hyponatremia. Hyponatremia is when the sodium level of the body is less than 135. Various literature talks about mild, moderate, and severe types of hyponatremia. That is with regards to the sodium levels. Of course, as I would talk to you more in the main part of the lecture, this mild, moderate, severe grade actually is not just only with the value of the sodium with regards to millimoles, but also with regards to the duration of the electrolyte disturbance. So just don't be misled by the fact that somebody has a value like this. Always look at the patient as a whole. So hyponatremia is the most frequently encountered electrolyte abnormality in clinical practice, and we see almost about 1/3, up to 1/3 in hospital settings, and it leads into potential life-threatening circumstances. It has been shown in various studies that it is an independent predictor of death in both critical and non-critical care centers, ICUs, geriatrics, and also with people who have deranged fluid balances, especially those who have heart failure and cirrhosis. But many of us, we think that it is confusing or frustrating to manage. Is it so? I pose this question to you. So hyponatremia can be present because of a relative deficit of sodium with or without a relative excess of water. A deficiency of sodium, as you would say, that when there is low sodium, it's hyponatremia, which can come along with or without an excess of water. So you see that there is a equation. You see that the equation is sodium concentration equals total body sodium over water. So therefore, hyponatremia will give rise, will come into existence because there's a decrease in the numerator, the one above, the fraction, or it can come with or without an increase in the denominator, the amount of water. So what are the clinical features of hyponatremia? So it is mainly neurological, and it is because that there is an intracellular water shift giving rise to cerebral edema. So the brain swells. So as I said before, just don't go by the figure that you get in a report of a renal profile or even electrolytes. The severity is not only because of the severity of the derangement, but also with the rate of development of derangement. We'll see why. So you also get acute hyponatremias and chronic hyponatremias. So acute stage is taken as 48 hours, within 48 hours of development. So if you see this picture, you see that on your left upper part, you see the normal brain with the normal osmolality. And when it encounters the immediate effect of hypotonic state, right? That is when there's hyponatremia in blood. So what does it have to do? There is shifting of water into the brain cells. And as you know, the brain is in a very confined space. It has hardly any space to expand. So the brain cell starts to swell up, and there can be rapid development of things, including uncal herniation. As you can remember, if you see your right upper part, you see cerebral edema, the brain swelling up, and then the brain matter trying to expand through the limited orifices or the various pores that are there inside the brain, therefore causing uncal herniation, brain herniation, and even death. But the body, if it adapts rapidly, you see that there is shifting of salt away from the brain cells, and the cerebral edema therefore becomes lesser. And there will be adaptation to it by formation of organic osmolytes. Various things like glycine, ammonia, etc., which just maintains the electrolyte balance inside the brain. Therefore, after slow adaptation or chronic hyponatremia, or after 48 hours, you see that the brain adapts to the level of the hyponatremia that is occurring elsewhere in the body. So what are the clinical features of hyponatremia? You see that in mild stages, you can get nausea, malaise, headache, irritability, confusion. This can happen even with a sodium level of 125 to 130 when it is in an acute within 48-hour period. Or it could happen in more than 48 hours when it drops to up to even 120 millimoles per liter. Of course, severe stages, you could get stupor, where there is complete confusion and poor engagement. There can be seizures developing, and very, if unfortunate, it can lead into coma. This happens when the sodium rapidly drops over 48 hours to 100 up to about 120, 125 without any adaptation, or even in a chronic stage at 110 to 120. Other than the neurological symptoms, you could get GI symptoms, again because of the swelling of the cells because of the edema, and also one could get muscle cramps and weaknesses. So how do you deal with it? The hyponatremia can be classified into 3 categories. You get the normal serum osmolality, the high serum osmolality, and more importantly, what we see commonly is low serum osmolality, which can occur with hypovolemia, hypervolemia, or euvolemia. So if I may reiterate, hyponatremia can have normal osmolality, high osmolality, or low osmolality. And low osmolality can manifest with high, normal, or low volume status. We will go one by one. So hyponatremia, normal osmolality, yes, you know, normal serum osmolality is between 275 to 290 milliosmoles per kilogram of water. So this could occur in these conditions, pseudohyponatremia and TURP syndrome. And more importantly, that if there are collection errors, it can be because of this. For instance, if there's a drip that is running on a peripheral vein, and if you collect blood from that arm, when there's blood going along that vein, you could get abnormal reading of a hyponatremia, but with normal serum osmolality. So that's a collection error, or what we call as drip artifact. So what is pseudohyponatremia? Pseudohyponatremia is when blood has a high content of plasma proteins and lipids, which expands the non-aqueous part of the plasma. So as you can remember, plasma is composed of the cellular part, the proteinaceous part, and the aqueous part. So if the proteinaceous part or the colloid part of the plasma is enlarged because of high plasma proteins or high lipids, you see that the plasma can expand in absence of normal amounts of water. So how do you get a high content of colloid constituents in plasma? This can happen if there is a very, very high triglyceride level in the lipid profile. Or it could happen when there is hyperproteinemia. So where does one get hyperproteinemia? The most important cause is multiple myeloma, where there is increased paraprotein production, and therefore you see that this colloid constituents can be raised. So this is something that you need to be mindful of. Not very common, but then you may see it in your practice. Then you also have this syndrome called TURP syndrome, or transurethral resection of prostate syndrome. So what happens after a TURP surgery, after the prostate is resected? What does the urologist do? The urologist initiates bladder irrigation, and there's continuous irrigation of bladder so that there won't be any clots implanting within the urinary system, causing clot retention and acute retention of urine. So what does this do? If the fluid that is given, the irrigant fluid that is given is absorbed, large volumes of absorbed irrigation fluid can give rise to a isoosmolar state, but it can dilute the hyponatremia. But it has become a rarity because now glycine-based irrigation fluids are less and less commonly used. But be mindful of this pseudo-hyponatremia and TURP syndrome in hyponatremia, normal osmolality. Now we come to hyperosmolar hyponatremia, where there is increased osmolality. How does this happen? This happens when there is osmotically active substances accumulating in the extracellular fluid. This causes dilution of sodium. It's also called translocational hyponatremia. The main example that you could give for this is hyperglycemia. If somebody has a very sugar content, let's say 400, 500, or even high index in the capillary blood sugar, they can have an errant hyponatremia report. So you have to be mindful of that. Again, TURP syndrome can present with hyperosmolar hyponatremia because of the fluids such as glycine, mannitol, sorbitol that are used. These are non-ionic, but they are osmotically active particles which can give rise to the bulk of the osmotic glucose, glycine, mannitol, all this. So you see that osmolar osmolar hyponatremia and hyperosmolar hyponatremia a bit rare, but you have to be mindful of this. But the more important one, what we see more commonly is the hypoosmolar hyponatremia. Hypoosmolar hyponatremia, when the serum osmolality is dropping. Serum osmolality is less than 280 milliosmoles per kilogram for water. What does it mean? It means that there is free water intake more than the water loss. Let's see how this happens. So hypoosmolar hyponatremia can be divided again into 3 types depending on the water content and the sodium content related to it. So what are they? It could be hypovolemic, as in dehydration, hypervolemic, as in states like cirrhosis, congestive cardiac disease, and nephrotic syndrome, or chronic kidney disease, or it could have apparently euvolemic status. I use the word apparently euvolemic status because clinically you don't see any dehydration that is going. So what are the causes of hypovolemic hypoosmolar hyponatremia? Hypovolemic is contracted volume, dehydrated, and the osmolality is less, and the salt levels are also less. This can be divided into 2. It could be renal causes or non-renal causes. So the renal causes are what causes salt to be lost in urine. So what are these? As in, the commonest example is diuretic use. If you see 10 people coming in your geriatric population, at least you would see 1 or 2 with hyponatremia going in. And most of them, they would be on diuretics, particularly thiazides. You use hydrochlorothiazides. You use indapamide, right? As good blood pressure controlling drugs. But you see that they are very, very prone to developing hyponatremia, and they may be dehydrated. There are other causes like salt wasting nephropathy, like cerebral salt wasting, which we will talk about in a while. People who are adrenally insufficient, like Addison's disease, they have salt loss because they don't have cortisol acting on the kidney, and then in the renin-angiotensin system, giving rise to salt retention. So you see that the urinary sodium content is great in them. If you take a spot urine sample, you would see that the urine sodium is more than 20 millimoles per liter. So those are the renal causes. Out of renal causes, the most essential what you would come across in your clinical practice, I would say, is this diuretic use, particularly thiazide use. Of course, furosemide, like loopioid diuretic, may also give rise to hypovolemic, hypoosmolar hyponatremia. Non-renal causes. How does the body get rid of the salt through other means than the kidney? Somebody has persistent diarrhea, profuse diarrhea. Somebody has relentless vomiting, they will lose the sodium. The patient is losing from the skin, excessive diaphoresis, hot environment, warm environment, excess exercise, or if there is denuded skin, let's say like in a burn or some kind of dermopathy where there is exposure of the dermis and underlying areas to the environment, one could lose the sodium. Some people restrict their salt. Rarely, also they could get hyponatremia in this mechanism. Third spacing, the commonest being any kind of intestinal obstruction or pancreatitis where there is exudation and there is a movement of fluid and electrolytes into spaces which are potential spaces. So you see that in these patients, the urine sodium is less than 20. Renal causes like diuretic use, the urine sodium will be more. In non-renal causes, it will be less. We come to hypervolemic causes of hyposmolar hyponatremia. This is more because of dilutional hyponatremia. So there is ineffective circulatory volume in these patients. Why? Because either there is a problem with regards to the proteins, let's say like in cirrhosis or nephrotic syndrome where there's oncotic pressure is less, and the effective circulatory volume becomes contracted, and why does that happen? Because there is translocation of water into the interstitial spaces. And you see that people who have congestive cardiac failure, cirrhosis, nephrotic syndrome, or chronic kidney disease, they are like swollen up. They look hypervolemic, but in fact, their effective circulatory volume is low. They have a state of secondary hyperaldosteronism. So these are people who can manifest with hyponatremia. But there are euvolemic hypoosmolar hyponatremia. That's also a very interesting area. Out of that, it's essential that you know that this entity called syndrome of inappropriate ADH secretion, or SIADH, very common in clinical practice, should be borne in mind. They are euvolemic. They are having normal volume status. Along with that, people who are thyroid deficient, as well as some people who are adrenal deficient, can also come across euvolemic hyposmolar hyponatremia. We'll talk about reset osmostatin in a little while. So if I may revisit what I have spoken of, sodium levels, when it is low, you have to have in the back of your mind, am I dealing with a peculiar condition where the solutes in the body are high? Is it because there is high sugar levels? If that is the case, it's a hypertonic hyponatremia. Check the sugar levels and see whether it's extremely high, 400, 500, high index, etc. Or is it because of something like a high lipid content or multiple myeloma? So these are things that you would get from the clinical history and the clinical appearance of the patient. More commonly, what you would encounter is hypotonic hyponatremia, where in that case, you need to check on the volume status. If somebody has hypervolemia, it looks hypervolemic, swollen up, then it could be because of heart failure, cirrhosis, or nephrotic syndrome. In such cases, there is low urine sodium because the body tries to conserve sodium as much as possible. Whereas in chronic renal failure, you would have high sodium levels in urine. You have to see whether the patient is contracted, hypovolemic. So whether the patient is on diuretics, whether the patient is on having a gastrointestinal problem, or whether there's a third phase. And again, you look at the urine sodium. If its urine sodium is more than 20, it's a renal loss because of diuretics or even cerebral salt wasting or additions. Or if it is low, urine sodium is low, then that means body is trying to conserve the salt, but the salt is lost from other areas other than the kidneys. It's the urine. So it's a renal, it's a non-renal loss like gastroenteritis. Of course, if somebody is euvolemic, then you have to check on the osmolalities and then decide on what it is. We'll talk about that. So ADH dependent clearance of water can be appropriate or inappropriate. So appropriate ADH secretion. Why? The body is giving the stimulus to produce antidiuretic hormone, keep more water, right? Because of hypovolemic state, hypovolemia. So hypovolemic hyponatremia, any cause of sodium loss can be there in anything like dehydration, diarrhea, vomiting, or even things like renal salt wasting, where there's stimulation of ADH. Or it can be in a peculiar way because the effective circulatory volume is contracted. People could be having hypervolemic hypernatremia. So these are people who are edematous. So whenever you see somebody edematous because of cirrhosis, nephrotic syndrome, chronic kidney disease, or even congestive cardiac failure, be careful when you say that patient is hypovolemic. In fact, the patient may be having a contracted intravascular space. That's the reason for the ADH secretion, the contracted intravascular space. Syndrome of inappropriate ADH secretion, or SIADH, is an important entity. This is a condition where there is water conservation happening in absence of an osmotic or volume stimuli. So the patient is clinically euvolemic. Patient is not edematous. Patient is not, doesn't look to be having hypovolemia. But there is a stimulus that causes body to preserve more and more water. And then there will be low sodium. So how does this happen? This can happen because of stimulation of the pituitary, posterior pituitary, or because of ectopic foci. So what are these? So any kind of brain pathology could give rise to SIADH. These are neuropsychiatric manifestations. May it be an infection like meningitis, encephalitis, a brain abscess. Or it could be because of a cerebrovascular accident, stroke, where there is swelling up of the brain, head trauma, or even acute psychosis. Acute psychosis because of non-metabolic reasons, right? Because of innate manifestation. So they can give rise to SIADH. Pulmonary diseases, any kind of lung pathology also can give rise to SIADH, ranging from pneumonia, lung abscess, tuberculosis, or even respiratory failure. Certain malignancies, including lung malignancies like small cell carcinoma of lungs, could give rise to SIADH. Particularly small cell carcinoma of lungs, they are known to secrete antidiuretic hormones. It's a paraneoplastic process. So they can manifest with SIADH. Pancreatic CA is also known to cause SIADH. Other than these causes, the other causes of SIADH includes drugs, which are encountered more and more in our clinical practice. So you see patients coming with increased ADH or ADH potentiation or ADH-like activity because of drugs. Any kind of antidepressants, especially SSRIs, which we use, or any kind of antipsychotic, lithium, or even drugs like carbamazepine can increase ADH. Certain cancer drugs like platinum and alkylating agents can also give rise to SIADH. ADH effect can be potentiated even by carbamazepine or any other kind of anti-epileptic drugs, and mind you, NSAIDs. And ADH-like activity occurs because of things like oxytocin and vasopressin and DDAVP. We use vasopressin and DDAVP for polydipsia and for hyponatremia. So you see that when vasopressin is actually antidiuretic hormone. So when you give the synthetic form of ADH, obviously the ADH-like action will worsen. How is oxytocin? Where do we use oxytocin? So oxytocin is used in partus as syntocinon, and when you give oxytocin, you see that mothers would become water intoxicated because of the ADH-like activity. If you can remember your physiology, oxytocin as well as vasopressin, they are synthesized in the hypothalamus together. They have the similar moiety and they are transported into the posterior pituitary and they get released by the posterior pituitary. So oxytocin has a ADH-like activity. That's how postpartum mothers could have hyponatremia and water intoxication. So what are the criteria to declare that somebody has SIADH? First and foremost, we have to remember that these patients are having hypoosmotic hyponatremia. So the serum osmolality should be less than 280. And because there is antidiuresis, syndrome of inappropriate antidiuretic hormone. So because of the antidiuresis, the urinary osmolality as well as urinary sodium levels will go up because the urine will get contracted. You see that the urine will get contracted because the body is trying to preserve the water as much as possible. This is another thing, not very much that we use, but you see that uric acid levels ought to be low in SIADH. Patients need to be euvolemic. Remember, SIADH doesn't, you can't say SIADH when somebody has hypervolemia, hypovolemia. Of course, SIADH can occur with hypovolemia if the patient with SIADH is dehydrated. But to say that SIADH, you need to have the patient has to be euvolemic. And conditions that stimulate ADH secretion like adrenal dysfunction, hypothyroidism, volume loss because of vomiting or nausea or diarrhea, those should be not. So this is the reason when you are evaluating somebody for hyponatremia, persistent hyponatremia, and you are thinking of SIADH, is essential that you exclude the presence of dehydration or volume overload status. Also, you need to see that whether the patient is having an underlying hypothyroidism or even Addison's disease. So that's where you need to do thyroid levels and cortisol. Cerebral salt wasting is something similar to SIADH. It resembles SIADH, but there is natriuresis. In SIADH, what happens is body has increased ADH production, and therefore body tries to keep more and more water within the circulating system. But in cerebral salt wasting, there is high BNP. There's natriuresis. There's loss of sodium in urine, giving rise to secondary ADH secretion. So what are the causes of cerebral salt wasting? It could be, again, any kind of neurological insult, just like SIADH, head injury, surgery, trauma, infections, anything. So you see that it may not be very easy to differentiate SIADH and cerebral salt wasting initially. And definitely the differentiating factor between SIADH and cerebral salt wasting is that in cerebral salt wasting, the patient will have hypovolemia, whereas in SIADH, it's either normal or a little bit high. So, and there will be both of these cerebral salt wasting and SIADH, they will have low serum osmolality, but the excretion or the loss of sodium in urine is greater in cerebral salt wasting compared to SIADH. And there will be more and more urine produced, whereas in SIADH, the urine production will be less or normal. So you see that you compare SiADH, you have inappropriate ADH in SiADH, which causes volume expansion because there's water being reabsorbed, and there is appropriate inhibition of sodium reabsorption. Therefore, in SiADH, you get urine loss, sodium loss in urine. Whereas in cerebral salt wasting, there is inappropriate inhibition of sodium reabsorption because of the increased ANP. Therefore, along with the salt, there is volume depletion. More and more urine is made and the patient goes into a hypovolemic state. And there is appropriate ADH and the urine sodium becomes higher. There is a condition called reset osmostat, where sometimes in the body, the stimulus to secrete ADH is made at a lower osmolality. The set point of serum osmolality is reduced, and therefore sodium level is lower, but usually this is stable most of the time, and it cannot be corrected. You would encounter these patients in your practice if they are pregnant, or in those who have decreased effective circulating volume, just like those who are in the tendency of going into heart failure, not established yet, tendency of going into heart failure, tendency of going into chronic liver disease, tendency of going into renal disease. So this is something that you see, but you are unable to, you cannot be safely correct. There are some people who have water intoxication. Who are these people? Those are those who ingest water in excess of the capacity of kidneys, occurs in hypogenic polydipsia, where there is more and more water drinking because of psychiatric manifestation. People can have beer potomania, people who drink more and more beer, or in older adults, tea and toast diet. Not necessarily to eat tea and toast, but they are people who have a frugal diet, who don't eat well. So they don't have minerals, nutrients, and proteins and calories, but they just eat just whatever they get, the tea and toast. So this can be also seen, just keep in mind. So how do you set about evaluating? First and foremost, look out for the normality of osmolality. Always at the back of your minds, check the sugar levels. Adjust the sodium for hyperglycemia. You get this equation, which you can get in your phones. There are calculators which are useful. You can easily download, where you put in the measured sodium and you put in the glucose level, and you get the adjusted sodium to find out really whether the patient is having a pseudo hyponatremia or not. Also, you can calculate the true osmolality by using this equation that we learned in the first term in medical college. Adding twice of sodium, adding the blood urea nitrogen with a correcting factor, and adding glucose to it. All these are in downloadable calculators. You just have to only substitute the values. Second thing is to check this urine osmolality. So in hypotonic, this is done in hypotonic hyponatremia. So if you get low urine osmolality, you have to think about those rare things, what I mentioned about water intoxication. That is primary polydipsia, beer potomania, tea or toast diet, or reset osmolality. But most of the time, what you would see is that the urine osmolality is more than 100 milliosmoles per kilogram. And thereafter, what you do is you have to assess the volume status, whether it's hypovolemic, euvolemic, or hypervolemic, and also look at the urine sodium by looking at whether the sodium is low or greater than 40. So depending on this, what we have discussed, I won't go into details again. There are additional tests that you could do. For instance, if you are thinking about SiADH or cerebral salt wasting, you could confirm it by looking at the uric acid levels. If you do an arterial blood gas, that would also give you some clues about certain things. For instance, if there's metabolic alkalosis and hypokalemia, that is because of vomiting or diuretics. Metabolic acidosis and hypokalemia is because of diarrhea or laxatives, going from the other way around. Or if there is hyperkalemia in the presence of metabolic acidosis in hyponatremia, are we dealing with an adrenal insufficiency? Always look at the thyroid profile and have a low threshold of checking for random cortisol in chronic hyponatremia to exclude adrenal insufficiency leading into pan-hypopituitarism. You can also do imaging. So management, you need to correct the patient's sodium by giving appropriate interventions and looking at the underlying disorders. Be careful of treating the patient in an overzealous way. Do not overcorrect hyponatremia suddenly. That can lead into a devastating neurological deficit. That's called osmotic demyelination, or it was called as central pontine myelinosis, where one could get flaccid quadriparesis, pseudobulbar palsy, mutism, convulsions, or even locked-in syndrome. Patient is conscious but unable to communicate. They are locked in. So when you do an MRI, you see that there's a hyperintense area in the pontine region. That's how this word central pontine myelinosis arises. So be mindful not to treat the patient in a overzealous way. So what happens there? So if you take your left lower picture, improper therapy causes rapid correction of these electrolytes. There is demyelination occurring in the brain, and there will be these manifestations coming. So if somebody has is acute symptomatic, somebody is very confused, having seizures and convulsions and then in coma, then you may need to rapidly act upon it. So you have to regularly check the electrolytes and may need to initiate hypertonic saline, that is 3% saline, to correct this. And mind you, what is the rate of correction that you want? You want not more than 1 to 2 millimoles per 4 hours. Thereafter, you increase the hyponatremia, correct the hyponatremia by 10 to 12 millimoles per liter over 24 hours. So what can you give? You could give boluses. You can give boluses of 100 milliliters each of 3% saline over 10 minutes, and these can be repeated up to 3 times till the symptoms are settled. So boluses of 100 milliliters of 3% saline given into 3 times. So the change in sodium required is taken by that, where you look at the sodium levels and the potassium levels in the infusion fluid, and you deduct the serum sodium levels and you divide it by the total body water plus 1. It's a correction. And thereafter, you determine the rate of administration. Again, I will not go into detail of this equations. These are there in your phones. These are there as apps where you can determine the rate of correction. So you need to be mindful of how to correct. So use those apps and correct it. So chronic asymptomatic hyponatremia, you don't correct rapidly like what you do for acute symptomatic hyponatremia, because you can push the patient into central pontine myelinosis. So you correct it in a modest rate, 4 to 6 millimoles per liter over 24 hours. Hypovolemic hyponatremia. Obviously, the patient is in dehydrated state. So if somebody is dehydrated and having hyponatremia, then the substance that you need to give is normal saline. If the duration is unknown, you give 1 liter of normal saline and you correct the hypovolemia. Of course, you need to correct the the etiology. If the patient is on thiazides, immediately stop it. You may need to give potassium also along. If the patient is having Addison's disease, you may have to give fludrocortisone long term. And also increased dietary salt is preferred. But remember, these drugs called Vaptans are not recommended for hypovolemia. We'll talk about that. Hypervolemic hyponatremia, please remember, you see that they are overloaded and hydrating, but don't go and give normal saline or oral salt just plainly to these patients. Don't give oral salt to patients who are having cirrhosis, heart failure, or liver failure. You need to restrict the fluid in these patients. So maybe up to about 1,000 to 1,500 milliliters per day, the water restriction is needed. And you need to get this excess water, which is there in the interstitial space, out of the body. So you will have to initiate loop diuretics. In heart failure, you have to use ACE inhibitors, or in hepatorenal failure, terlipressin can be used. If the patient is symptomatic, then you can give 3% saline to control the symptoms of seizures or confusion. But don't use injudiciously salt or 3% saline. So oral salt supplementation, essential that you need to know that patients with uremia can be treated by oral salt tablets, or in our setting, we can give salt as teaspoons. So usually what we say is 1 gram of oral salt is equivalent to 35 milliliters of 3% saline, or 9 grams of oral salt is equal to 1 liter of normal saline. So one teaspoon, that comes to 6 grams of salt, has about 2.5 grams per grams of salt. So do not give, and also do not give salt to edematous patients. You can use Vaptans. Vaptans are the newer drugs, the new kids on the block. These are V2 receptor antagonists. They can be used in euvolemic patients like in SIADH, or in hypervolemic patients. Tolvaptan is the one that is available in Sri Lanka, and these can be given. And hyponatremia corrects as long as the Vaptans are going on. So you need to address the causative factor of hyponatremia. Don't think that by just giving a Vaptan, Tolvaptan 15 milligrams daily, you have done your job. You need to look into and see what is the reason for this hyponatremia. So remember, never give Vaptans to those who are dehydrated or having volume shrunken state. You can give Vaptans in heart failure. There are studies which have been proven to have improvement of hemodynamic status, but there is hardly any mortality morbidity benefits as of shown as now. Cirrhosis also you could use, but there's no benefit in mortality, bleeding, hepatic encephalopathy, etc. What do you do for SIADH? When you are thinking of SIADH, always think whether am I missing hypothyroidism or Addison's. Treat the causative factor, whether it's drugs, or whether it is an infection, or whether it is a lung condition. Water restriction is the main cornerstone of treatment. You restrict up to 1,000 to 1,500 per day. Diuretics are when Vaptans are used. There is a drug called demeclocycline, which is tetracycline that can be used, but not used in our setting, not available. But Vaptans are useful. If there are acute severe symptoms, then 3% saline can be used. Cerebral salt wasting, you need to correct the volume replacement and of the urine sodium loss. So, but they will need a long-term oral salt supplement because their salt is being wasted. So a few cases and then we'll wind up. So we have a 57-year-old man who is found unconscious at home. He has a GCS of 12. He's confused. He is not having fever and he's not dehydrated. His cardiovascular status is satisfactory. He comes with a seizure and you find that his sodium levels are very low. His CT is normal. What do you do? What can you give? Is it giving saline, normal saline? Is it giving oral salt, waiting for the reports to come? Or are you going to start on sodium valve? What you need to do is to give 3% saline and correct this patient's abnormal these symptoms as soon as possible. Case 2, you have a 75-year-old lady. These are people that come to you more frequently. Unable to cope, having recurrent falls, multiple body aches, pains, this, that, and everywhere. Right? Patient is having hypertension and diabetes on multiple drugs, including metformin, sitagliptin, nifedipine, hydrochlorothiazides, vitamins. She looks euvolemic, blood pressure and heart rate are fine. Sodium has been 110. You look at her clinic book and you find that the sodium is ranging between 125 to 130 before. What is the likely cause for this presentation? So this is likely the drugs, what is this, hydrochlorothiazides rather than SIADH per se. How do you differentiate hypovolemic hyponatremia from SIADH? Both will have serum osmolality of low serum osmolalities and both will have urine osmolalities which are high. But you see that in thiazide hyponatremia, the urine sodium is low, whereas in SIADH it is high. So urine sodium is usually high in SIADH, whereas in hypovolemia it is low. So it is likely dehydration because of the drug, because of the thiazide. So what do? You need to stop the hydrochlorothiazide. You need to rehydrate with saline and you need to supplement with salt. Third and last case, you have a 76-year-old male with 1 week history of confusion, recurrent falls. He was fit and well 1 month back. But the family doctor has started him on some drugs for low mood and memory issues. Examination is unremarkable and he's euphemic. Sodium is low, CT is normal. You see that the osmolality, serum osmolality is low, urine osmolality is high, and urine sodium is also high. Thyroid and cortisol are normal. So what is this? This is likely drug-induced SIADH. So drugs, patients may have been started on antipsychotics or antidepressants, and that has led to SIADH. How do you treat him? Provided that he's not dehydrated, you have to restrict the fluid intake 500 ml below the urine output. Mind you, essentially, stop the drug, do not restrict sodium. If you need to do rapid correction, 3% saline is used. Here we can use tolvaptan. One last slide. Do not give 0.9% saline in pure SIADH. Because what happens when you give 1 liter of normal saline, all of the sodium chloride will be excreted, because in SIADH, the sodium handling is intact, right? So what happens is when you give 1 liter of saline, half of that will remain, water will remain as free water and will further reduce the concentration of sodium and cause more and more hyponatremia. You are doing more harm by giving saline. So hyponatremia should be evaluated carefully, correct the causative factors, be mindful of the level and duration of derangement and the rate of correction as we discussed. Be careful not to overcorrect. You may be doing it with a good intention, but do not make the treatment more grievous than the disease itself. One of the points in medical ethics and medical professionalism. Do not give normal saline or oral salt to edematous patients that will cause further worsening. Do not give 0.9 saline in SI-ADH unless there is evidence of dehydration. And you're using 3% saline and vapors, be very careful how you are doing it. You may have to do repeated electrolytes. If you can remember the talk by saying that hyponatremia is when the body loses its savor. In our clinical practice, also in our human life as well. If we have the saltiness, and if our saltiness, which is craved, which is the cause that is the goodness in us, is lost. Therefore, when our goodness and our intentions are lost, there's no point in us. When the salt loses its savor, or when the salt loses its saltiness, it is nothing but to be cast out and be trodden under the foot of men. Thank you.
Dr. Shyam,
Yes.
thank you for that fascinating lecture. Actually, there's a lot of things to learn even fast here. And can you kindly switch on your camera, please?
Yeah, sorry, Himal, I had to close that because my internet was getting unstable.
Right,
so I want.
Right.
I think
Sure,
it's now.
Sure. Shall we proceed into the Q&A session?
Yeah, yeah.
Right. We got a pre-evaluation questions as well. So we'll start by one. What is the pathophysiology explanation for hyponatremia in hyperlipidemia and hypertriglyceridemia in CCL/CD? So you have explained that.
Yeah, sorry, if I tell them what is the hyperlipidemia and
what is hyponatremia in hyperlipidemia and hyperglycemia and CLCD?
So as I mentioned, in hyperglycemia, what happens is there is increased sodium levels, which will give rise to a pseudo hyponatremia, right? Because the space becomes more, right? Because there's more water. In hyperlipidemia and hyperproteinemia, what happens is the plasma volume expands and not the water volume. So therefore, the plasma volume expands more and more. The sodium level is the same, the water level is the same, but what is below the denominator increases. So if you can remember that equation that I said, for you to say hyponatremia, either the salt level, which is on top, the numerator has to go down, or what is below, the water or the volume content has to go up. So that's what happens.
Right. Next question is, why is hyponatremia very common in elderly rather than we see in young?
Okay, good question. There are many factors. Number one is, as you know, older people have altered homeostasis, right? So all the mechanisms of maintaining homeostasis with regards to ADH, angiotensin, aldosterone, cortisol, all those things are deranged. So therefore, they will not be able to maintain the status, correct the hyponatremia easily. Number two is they have other multiple factors coming to polypharmacy, as I mentioned. Polypharmacy with regards to thiazides when people are on diuretics. Also, if they are on memory-related drugs or psychiatric drugs, maybe antidepressants or antipsychotics, those will also contribute to hyponatremia, not necessarily one thing. And also the tea and toast diet and poor nutrition. So tea and toast diet is not necessarily drinking tea and toast, but they are not fortifying themselves well with their calories and proteins as well as the minerals. So what they eat are just empty calories, and they have problems. And also, as one age, the kidneys also, there's chronic deterioration of kidney functions. They can go into salt losing status, chronic kidney disease. So a lot of factors come into stay.
Yeah, this is regarding what the osmolality of the serum. What is the osmolar gap and what is the relevance to the hyponatremia?
So osmolar gap is, that's where I mentioned, if I'll share that again, the equation moment. So when you are with a patient and you are thinking about osmolar gap, if you look at the equation below, serum osmolality is normally contributed by 3 factors. Sodium into 2. Actually, sodium into 2 is actually, this is sodium chloride, giving rise to that factor. The blood urea levels and the blood glucose level. So this is the main main 3 factors that give rise to the osmolality determination in a normal person. But in certain patients, you can have a hyperosmolar state where it's because hyperglycemia or because of circulating proteins or lipids, colloid fraction that increases. So then you need to see whether there is a extraneous substance, whether there is a contributory substance giving rise to this osmolar gap. That's where this osmolar gap comes. What you calculate through that equation is what is the normal constituents that should be in the body. But the value that you get in the blood report, in the serum osmolality report, may be a higher level. So osmolar gap is that discrepancy that is there.
The next question, differentiating SIDH with 2 conditions. First, SIDH was primary polydipsia. The second one is SIDH was cerebral salt wasting.
So cerebral salt wasting and SIDH, I think I mentioned about that. If I may go again, I'll show that slide. So main thing is in SIADH, it's a euvolemic state, whereas cerebral salt wasting, it's a contracted space or dehydrated space. But the issue is it's not very clear sometimes to differentiate these 2 entities, as in cerebral salt wasting. More common is SIADH in your clinical practice. Cerebral salt wasting could also be there, because both SIADH and CSW will have similar etiologies. So, but clinically, it might not be easy to differentiate this dehydrated manifestation or contracted space. So then you need to look at the urine sodium levels in the patient. So when you see the urine sodium levels, it will be sky high in cerebral salt wasting. It's a salt wasting nephropathy. So that's where you see. Another thing is, I think I put it in the MCQ also, is you see that in cerebral salt wasting, you might get a higher level of hematocrit because there is contracted volume, contracted space. So that's how you differentiate. But it's not a very easy thing to differentiate. Of course, when you are treating SIADH, and you have been doing all these things and you are giving a therapeutic trial, but it's hardly not getting controlled. So then you have to think about cerebral salt wasting. The other one, what he asked was about the primary polydipsia, is it? Okay, so
primary
SIADH. So again, so primary polydipsia, of course, unless the patient is concealing the history that he's drinking liters and liters of water, you won't be able to differentiate with from SIADH clinical. Of course, patients with primary polydipsia, they may be having underlying psychiatric illness, so that will be may be pointed towards primary polydipsia. But as you can see, SIADH and primary polydipsia will have euvolemic state, and the urine sodium levels will be more. But you see that if you have the facility and if you are able to do it, check the urine osmolality. You see that the urine osmolality is higher in SIADH. Why is that? It's syndrome of inappropriate ADH secretion. So ADH is concentrating the urine, antidiuretic. Whereas in urine osmolality in primary polydipsia will be low. Why? Lot of excess water that has been taken is has been ingested is lost as urine. Why? ADH secretion becomes almost zero. The doesn't want excess water.
Right. Next couple of questions coming on the management of hyponatremia. Correction of hypokalemia with regard to hyponatremia.
Yes. So we concentrated here mainly on the hyponatremia, right? Of course,
Yeah.
if somebody is on diuretics, you may encounter other electrolyte disturbances also, not only potassium, also even calcium. So you need to look at all those things as well. So if that is the case, then you need to judiciously correct hypokalemia depending on what the severity is. Let's say if somebody has 1.5, 1.4 millimoles per liter, and that is not, it's life-threatening hypokalemia, then you will have to add potassium into the saline. So we usually with thiazide that you get this issue. So then when you're hydrating the patient, you will have to give KCl as, let's say, 20 millimoles or 40 millimoles, and then you give it as an infusion and you correct it depending on what the severity is.
Next question regarding the hypertonic saline in the clinical setting. I think this is one of the questions we have discussed thoroughly. So what are the targets? You have mentioned the targets. What are the actual clinical setting you use, and how much you're going to use in hyponatremia if you want to use hypertonic saline? Yeah.
So it all depends on whether the patient is acutely symptomatic or whether there is no symptoms at all. So again, I tell you, don't try to memorize these equations. These are there in your phones, in your computers, in whatever, in your tabs. So all you want to need is to substitute it. Essential thing that you need to do is, if somebody is acutely symptomatic, somebody is having coma, somebody having seizures, somebody is deteriorating GCS as you see, then you need to act rapidly. Then you need to give maybe boluses, as what is described in the American endocrinology societies and even the internal physicians. They give boluses of 100 milliliters of 3% saline over 10 minutes. Mind you, when you are doing this, you need to ensure that you have a proper way of looking at the salt levels regularly. So that has to be established in your system. Otherwise, you may cause harm. If somebody has chronic asymptomatic hyponatremia, then you can take time, right? Then you take like 4 to 6 millimoles per liter rice over 24 hours. So the rate of giving 3% saline may be even like 20 milliliters per hour, 30 ml per hour, depends on the weight, depends on the sodium that is there, depends on the chronicity that is there in the patient. So don't have a blind thought in your head saying, just like you're giving 100 milliliter boluses of 3%, but in chronic asymptomatic hyponatremia, you need to calculate and carefully give that. So use your calculators.
Right. The last question. Our audience need a guideline to refer if we have come across in next time.
Yeah.
Any particular guideline you are recommending?
So the guideline that is there is in, wait, I'll tell you the exact year. There is a guideline from the American Endocrinology Association. Wait, give me a moment.
Actually, you can send to us, then we can distribute among our.
Actually, I'll send this as a PDF presentation. You can share it with the audience. I'll send it. I'll send this guideline. Plus, I'll send this presentation as a PDF. Right? Okay.
Right. Thank you. And for the audience and you, we are recording this event, and it will be uploaded to our YouTube channel. You can always go and look for it, and for your further reference. And if there's any new questions coming up, I think we can conclude session. First of all, I would like to thank Dr. Shehan Silva for joining us in a remote place, even though we couldn't have start up our own studio today. And secondly, I would like to thank Sri Lankan College of Internal Medicine to coordinating this with Sri and GOMA for our lecture. And last on the list, I have to thank our all audience who have participated with us. And I think we have more than 150 participants today. Thank you for all. And I would like to thank my team at Sri for all these arrangements. Thank you. Dr. Romali, session is now over to you.
Thank you.
Thank you very much, sir, and Dr. Himal for joining us today for this very interesting and timely topic. Please subscribe to our YouTube channel, GMOA Sri Knowledge Academy. We will be uploading this lecture, and also the previous lectures are already uploaded. Subscribe and please click on the bell button so that if there is anything new uploaded, you will get a notification. We also have our GMOA Sri Facebook page active now. We are trying to be interactive and post more questions from the upcoming lectures for you to discuss. We are also working on a system of trying to send you a marking scheme for the post-evaluation questions. So please bear with us. If you have any suggestions to improve our programs, please get in touch with us and let you know. And hope you all have a very good Sunday and a nice week. And hope to see you all next Sunday with a new webinar on a new topic. Thank you.